Okay, let's unpack this. The world of mental health nursing, it's huge, right? And sometimes, well, pretty complex.
Definitely.
Today, we're really diving into one of the most critical areas, depressive disorders. It's all about seeing the whole person, their whole experience,
Mm.
and figuring out how you as a future nurse can genuinely help and use this knowledge day to day in your practice. We're using Varkarola's Foundations of Psychiatric Mental Health Nursing, the 8th edition,
Yeah.
as our main guide here. It's pretty much essential reading.
It really is. And for you listening, especially if you're a nursing student, our goal here is to, well, cut through some of the density. We want to pull out the absolute need-to-know stuff. For your exams, yes, for the NCLEX, but honestly, more for when you're actually with patients.
Right.
So not just what these disorders are, but why they matter to people and how you can apply this knowledge, holistically.
Okay, so let's start with the basics. These depressive disorders, they seem to share some core features.
They do. At their heart, you're looking at things like feeling sad, empty, sometimes really irritable.
And physical stuff, too.
Yeah, somatic concerns pop up a lot, plus problems with thinking clearly. And all of this really impacts a person's ability to just function day to day.
Gotcha.
And it's super important to remember, depression isn't just one thing. Major depressive disorder, or MDD, is the one most people think of, but there's actually several distinct types.
Okay.
Take disruptive mood dysregulation disorder, DMDD. This actually came about partly because, well, there was concern about bipolar disorder being overdiagnosed in kids.
Ah, interesting.
So DMDD applies to kids and teens, say 6 to 18, but it has to start before age 10. The main things you see are constant, severe irritability and anger. And these really frequent temper tantrums, like way out of proportion to the situation, happening multiple times a week.
Wow.
And it needs to be happening in different places, like at home and at school. For you as a nurse, knowing this helps avoid mislabeling and points towards treatments focused on symptoms, maybe CBT, and definitely parent training.
Makes sense. What else?
Then you have persistent depressive disorder, used to be called dysthymia.
Right, I've heard that term.
Yeah. Think of it as this kind of chronic, low-grade depression, feeling down most of the day, more days than not, for at least 2 years straight in adults.
2 years.
Or 1 year for kids and adolescents. They might have changes in appetite or sleep, low energy, feeling bad about themselves, trouble concentrating, feeling hopeless. Patients often say something like, "I've just always felt this way." It's usually not bad enough to need hospitalization, but it definitely messes with their quality of life.
That sounds exhausting.
It really is. Then there's premenstrual dysphoric disorder, PMDD. This is more than typical PMS.
Okay.
We're talking significant mood swings, irritability, depression, anxiety, even physical symptoms, all happening in that week before menstruation starts. And then, crucially, it gets better once menstruation begins. It causes real distress. Lifestyle changes often help diet, exercise, and sometimes specific SSRIs are approved for it. And 2 more related ones. Substance medication-induced depressive disorder. Pretty straightforward. The depression is a direct result of using a substance for a while, or maybe withdrawal.
Okay.
The key thing for nurses here is that these symptoms usually clear up, within a few weeks after the substance is stopped.
So removing the cause is key.
Exactly. And similarly, depressive disorder due to another medical condition. This really highlights that mind-body connection.
Yeah.
Depression can absolutely be triggered by other medical issues. Think about conditions like stroke, Parkinson's disease, hypothyroidism, chronic pain.
Right.
They can all manifest with depressive symptoms. And critically important for your assessment, always review the patient's medication list. Varkarola's has a table 14.1, that lists examples, but things like beta blockers, steroids, even some painkillers can sometimes trigger depression. It's a huge part of holistic assessment.
That really paints a picture of how varied depression can be. Okay, so now let's focus on the big one, the one people usually mean when they say depression. Major depressive disorder, MDD.
Right. And this one is, well, incredibly common. It's actually the leading cause of disability in the U.S. We're talking millions of adults affected.
Millions.
Yeah. Numbers from a few years back showed around 16 million adults in the U.S. It tends to be diagnosed more often in women than men, and unfortunately, it often comes back high recurrence rate.
Okay, so clinically, how is MDD actually diagnosed? What are the criteria?
So the DSM-5 lays it out. For a diagnosis, someone needs to have 5 or more specific symptoms, and these have to be present during the same 2-week period. And here's the crucial part. At least one of those symptoms must be either a depressed mood most of the day, nearly every day, or a significant loss of interest or pleasure in activities that's anhedonia.
Okay, so one of those two is essential.
Absolutely. Then the other symptoms making up the five or more can include things like major changes in weight or appetite, sleeping too much or too little, feeling constantly tired or having no energy. Also, feelings of worthlessness or excessive guilt, trouble concentrating or making decisions, and importantly, recurrent thoughts of death or suicide.
That brings up something complex.
Yeah.
What about depression and grieving? How does that fit in? I know there used to be some specific rules.
Yeah, historically, there was what they called the bereavement exclusion. Basically, if someone had just experienced a major loss, like the death of a loved one, clinicians were generally advised not to diagnose major depression within the first couple of months.
Why was that?
The idea was to avoid pathologizing normal grief. Grief involves intense sadness, but it's considered a normal human response.
But that changed.
It did with the DSM-5. Now, you can diagnose major depression even during a period of grief.
What was the reasoning behind that shift?
Well, a couple of things. First, intense grief is a major psychological stressor. And like any big stressor, it can actually trigger a full major depressive episode.
Right.
And second, waiting a set time, like 2 months, could mean delaying necessary treatment for someone who is genuinely clinically depressed, not just grieving, potentially making things worse for them. It really highlights how tricky it can be to distinguish profound sadness from clinical depression sometimes.
Yeah, that's a fine line. So what puts someone at higher risk for MDD in the first place?
It's definitely not just one single cause. It's almost always a mix. Biology, psychology, life experiences, the environment.
Okay, let's break that down. What about the biological side?
Well, genetics certainly play a part. Studies looking at twins show that if one identical twin has depression, the other has about a 50% chance of developing it too.
Wow, 50%.
Yeah, it suggests multiple genes are involved, not just one depression gene. And often, these genetic vulnerabilities interact with things like stress or maltreatment early in life.
And biochemically, neurotransmitters.
Absolutely, that's a huge area of focus. Two key players are serotonin and norepinephrine. Serotonin affects things like sleep, appetite, sex drive, mood. And norepinephrine is involved in attention, behavior, energy levels. When these systems are out of balance, it can really contribute to depressive symptoms. Varkarolus even includes a figure, like a PET scan image, showing differences in brain activity between someone depressed and someone not, or before and after antidepressants. It visually represents that something is functionally different in the brain.
So it's not all in their head in a dismissive way.
Not at all. There are real biochemical changes. Hormones are involved too. The HPA axis, that's the hypothalamic-pituitary-adrenal axis, your body's main stress response system, often seems to be hyperactive in depression.
Meaning more stress hormones.
Exactly, like cortisol. This chronic overdrive of the stress system contributes to the problem. There's even a test, the dexamethasone suppression test, though it's not perfectly reliable, that can sometimes show this HPA axis issue.
Oh, interesting.
And another fascinating area is inflammation. Research is showing links between markers of inflammation in the body, like C-reactive protein and depression, especially in people who faced significant adversity.
So like chronic stress leading to inflammation, which links to depression.
That seems to be part of the puzzle, yes. It all ties together in what we call the diathesis stress model.
Okay, explain that one.
It's a really important concept for nurses. The diathesis is the underlying vulnerability could be genetic, biological, maybe even psychological. The stress refers to life events, trauma, loss, major changes. The model basically says that depression often arises when someone with a pre-existing vulnerability encounters significant stress.
So that's why two people might go through something similar, but only one gets depressed.
Precisely. It explains why responses differ. And it highlights why our nursing interventions need to be holistic, addressing not just biology, but also helping people cope with stressors and build resilience. We're trying to manage both sides of that equation.
That makes a lot of sense.
Go.
Okay, beyond the biological, what about the psychological factors? Thoughts, maybe?
Huge factor. This is where cognitive theory comes in, especially the work of Aaron Beck.
Beck, right.
His core idea is that our thoughts powerfully shape our emotions. People with depression tend to have these negative, often illogical, automatic thought patterns that get triggered by stress.
Like a negative filter on everything.
Pretty much. Beck described the cognitive triad. It's a three-part pattern: a negative view of oneself, I'm worthless; a negative view of the world, everything is awful; and a negative, hopeless view of the future, nothing will ever get better.
Wow. That sounds like a recipe for depression.
It really is. And these negative thoughts often happen automatically, almost unconsciously, feeding the depression. Understanding this is crucial because it's the foundation for cognitive behavioral therapy, or CBT, where we help patients identify and challenge these thought patterns.
So as nurses applying the nursing process, where do we start? Assessment seems key.
Absolutely paramount. Early recognition and intervention are where nurses can make a massive difference. We're often the first point of contact, the ones doing the initial screening and assessment.
And we have specific assessment tools for that.
We do. Beyond just asking general questions, we use standardized tools. A really common one you'll use is the Patient Health Questionnaire 9, the PHQ-9.
Okay, what's that like?
It's super straightforward, just 9 questions. It asks the patient, over the last 2 weeks, how often have you been bothered by? And then lists things like little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble sleeping, poor appetite, things like that.
And how do they answer?
They rate each item on a scale from 0, meaning not at all, up to 3, meaning nearly every day. You add up the scores, and the total gives you a pretty good idea of the severity: minimal, mild, moderate, or severe depression. It's quick, easy to use, and helps guide our next steps.
That sounds really practical.
It is, but arguably the most critical part of any depression assessment is looking at suicide potential.
Right. The most dangerous aspect.
Absolutely. We have to ask. Suicidal ideation isn't just one thing. It can range from vague, passive thoughts like, I wish I wouldn't wake up, to very specific, detailed plans.
So how do you ask? Is it awkward?
It can feel awkward at first, but it's essential. We use direct questions. Things like, have you been having thoughts about taking your own life? If yes, then, do you have a plan? Do you have the means to carry out the plan?
You have to be direct.
You do. Asking doesn't plant the idea. It opens the door for them to talk about something that might already be weighing heavily on them. We know risk goes way up if someone feels hopeless, if they're using substances, if they've had a recent loss, or especially if they've attempted suicide before.
Okay.
But here's a really sobering statistic Varkarolus mentions. One study found that 86% of people who died by suicide had no documented previous attempts.
86%. Wow.
Yeah, it just underscores why we need to assess everyone thoroughly every time. We can't rely only on past history. Early detection is vital.
Okay, so beyond the screening tools and suicide assessment, what are some other key assessment findings we should look for? What does depression look like?
Well, think about affect. That's their outward emotional expression. Often, it's described like they're seeing the world through gray-colored glasses. You might see slumped posture, sad facial expression. Their affect might be blunted, meaning very little expression, or even flat, like no expression at all. Poor eye contact is common, maybe frequent sighing.
And their thinking. You mentioned impaired thinking earlier.
Right. Thought processes are often affected. Thinking can be slowed down. Judgment might be poor, leading to indecisiveness. They just can't make choices. Memory and concentration often suffer.
Yeah.
Negative thoughts can be really intrusive and hard to shake. In very severe depression, someone might even become mute, unable to speak. And sometimes you see delusional thinking. Varkarolus gives an example, like a patient believing, I am responsible for Elvis Presley's death because I...
Seriously, that's specific.
Yes, delusional guilt can be that specific and fixed. Recognizing that isn't just about spotting a symptom, it tells you about the depth of their suffering and how distorted their reality has become. Your approach needs to be gentle, but grounded in reality.
Okay. What about their internal experience, their mood and feelings?
Mood is what the patient tells you they feel. A hallmark symptom, as we said, is anhedonia. They just can't find pleasure in things they used to enjoy.
Nothing feels good anymore.
Exactly. And in terms of feelings, you see a lot of worthlessness. I'm no good. I'm a failure. Guilt is incredibly common, often about things they aren't even responsible for. Helplessness shows up as feeling unable to manage even simple daily tasks. And hopelessness, that feeling that things are terrible and will never change. That's a really dangerous one, strongly linked to suicide risk.
Yeah, that makes sense.
Anger can be there too, but often it's turned inward, contributing to the self-blame and worthlessness.
And then there are the physical aspects, right? The physical behavior.
Yes, often called the vegetative signs of depression. Big one is anergia, just a profound lack of energy, feeling utterly drained.
Like moving through mud.
Exactly. This can manifest as psychomotor retardation, where movements, speech, everything is slowed down, or sometimes the opposite happens. Psychomotor agitation, where they can't sit still, pacing, fidgeting, wringing their hands.
Interesting. It can go either way.
It can. Appetite changes are classic, either significant weight loss or gain. Sleep problems are huge: insomnia, waking up super early and not being able to get back to sleep, or sometimes hypersomnia, sleeping way too much.
Okay.
Changes in bowel habits, often constipation. Decreased libido is common too. And you'll often notice neglect of personal grooming and hygiene. They just don't have the energy or motivation.
That's a lot to look for. Does it look different depending on age?
Definitely. Age considerations are important. In kids, depression might show up more as irritability, acting out, maybe refusing to go to school, sometimes substance use in teens.
Right.
In older adults, it gets tricky. They might focus more on physical complaints, aches, pains, fatigue, rather than saying, I feel depressed. Sometimes the cognitive effects, the trouble concentrating, and memory issues can look like dementia. We call that pseudo-dementia. Using something like the geriatric depression scale can be really helpful.
So as the nurse dealing with all this, it must be challenging. What about self-assessment for us?
Oh, absolutely critical. Caring for someone who is deeply depressed, maybe withdrawn, negative, seemingly resistant to help. It can be frustrating. It's easy to feel like you're not making progress.
Yeah, I can imagine.
So you have to be aware of your own feelings. Are you getting frustrated? Are your expectations realistic? Understanding the illness helps, knowing that negativity and lack of motivation are symptoms, not the person just being difficult. You need to separate your own feelings to stay therapeutic and avoid burnout.
Good point. Okay, so after assessment comes diagnosis. What are the key nursing diagnoses?
Number one priority, if the assessment indicates it, is always risk for suicide. That trumps everything else.
Always safety first.
Always. Other common ones might be things like chronic low self-esteem, ineffective coping, disturbed sleep pattern, social isolation, self-care deficit. Varkarolus has a helpful table, Table 14.2, that links common signs and symptoms to potential nursing diagnoses and desired outcomes.
And the outcomes identification and planning. How do we set goals?
We really work within the recovery model. The idea is that healing and recovery are possible, even with severe depression. So goals need to be patient-centered. What does the patient want to achieve?
Makes sense.
They should be mutually agreed upon, realistic, and measurable. And of course, planning always includes ongoing safety assessment. Treatment usually happens in phases. An acute phase, maybe 6-12 weeks, focused on reducing symptoms. A continuation phase, 4-9 months to prevent relapse, and sometimes a maintenance phase, a year or more, to prevent future episodes altogether.
All right, let's talk implementation.
Yeah.
What are the key therapeutic interventions, especially things like counseling and communication? How do you talk to someone who might be really withdrawn?
It can be tough. Silence, for instance, can feel uncomfortable for us as nurses. We want to fill the space. But sometimes just sitting with someone in silence is therapeutic. It shows you're present and accepting. When you do speak, try making simple observations about the environment or the patient. You are wearing new shoes today, or I see you combed your hair. It doesn't demand a deep response, but shows you're paying attention.
Okay, so less pressure.
Exactly. Use simple, concrete words. Allow plenty of time for them to respond. Remember, their thinking might be slowed. And listen very carefully for any covert messages, especially hints about suicide, and then address those directly but gently.
And what not to say.
Oh, definitely avoid platitudes. Things like, cheer up, things will look up, or you have so much to live for. It sounds helpful, but it often minimizes their pain and makes them feel misunderstood.
Right, invalidating.
Exactly. Varkarolus outlines some great counseling guidelines, too, often related to CBT principles, helping patients question their negative assumptions. Identifying those cognitive distortions we talked about, like overgeneralizing, I failed one test, so I'm a total failure, or self-blame or mind reading, I know they think I'm stupid.
So challenging those automatic negative thoughts.
Yes, gently helping them see things differently. Also, exploring coping skills they've used before, encouraging things we know help, like exercise, building supportive relationships, maybe connecting with spiritual support if that's important to them.
Can we look at the case scenario, Ms. Klesner? How does this play out?
Okay, yeah. So, Miss Glesner is 35, a nurse herself, actually, comes in saying she's been depressed as long as she can remember. Recently broke up with her partner, feeling hopeless, made some superficial cuts on her wrist.
Okay, definite risk factors there.
Right. On assessment, her affect is blunted, poor eye contact. She mentions drinking alone at night, sleeping all weekend. When the nurse, Carrie, talks to her, Miss Glesner says, I just want to get away from this pain.
How does Carrie respond?
Therapeutically, she reflects it back. You want to get away from your pain. This simple reflection encourages Mrs. Glesner to say more. She talks about feeling fat, Ugly, not good enough, linking it to past relationships. Carrie gently challenges the distortion. You think because Jerry went back to his wife that no one else could care for you. Then she explores support systems. Who is in your life that supports you?
Trying to find strengths.
Exactly. And Miss Glessner mentions her sons, although she feels ambivalent, like she's failing them to.
So what's the care plan focus?
Priority number one is risk for suicide. Interventions include things like checking on her every 15 minutes, removing potentially dangerous items from her room. The rationale is safety, obviously, but also conveying that she is worth protecting.
And other interventions.
Spending scheduled time with her, even if she doesn't talk much. Assisting her to identify positive aspects about herself, even small ones. Encouraging contact with her sons or other supports.
And did it help?
The case suggests it did. One outcome was for her to state a reason to live. Eventually, she identified her sons as that reason, saying she wouldn't want to hurt them. It shows how connecting, even briefly, can uncover those protective factors.
That's powerful. What about health teaching and health promotion?
Huge nursing role. We need to empower patients with knowledge. Teach them that depression is a real, treatable medical illness, not a weakness. Explain their medications, what they do, side effects, why it's important to keep taking them, even when feeling better.
And relapse prevention.
Yes, help them identify early warning signs of relapse. Stress the importance of ongoing therapy like CBT or IPT and involving family for support, if appropriate. Knowledge is power here.
And practical self-care.
Absolutely. Promotion of self-care activities is key. For poor appetite, maybe suggest small, frequent, calorie-dense snacks instead of big meals. For sleep issues, encourage a routine, getting out of bed during the day, maybe relaxation techniques before sleep.
And basic hygiene.
If they're neglecting self-care, break it down into small, manageable steps. Let's just start with brushing your teeth, gentle reminders. And for constipation, which is common, encourage fluids and fiber.
It sounds like a team effort, and safety is always hovering.
Definitely. Teamwork and safety are critical. You're working with doctors, therapists, social workers, and yes, safety, especially regarding suicide risk, is paramount.
What do suicide precautions actually involve on a unit?
It depends on the level of risk, but it can mean removing everything potentially dangerous sharps, like razors, belts, or cores that could be used for strangulation, sometimes even checking belongings very carefully. Medications are kept locked up, and observation levels increase. It might be checks every 15 minutes where you have to physically lay eyes on the patient. Or, for very high risk, it could be continuous one-to-one observation, meaning a staff member is with the patient 24/7.
Wow, constant vigilance.
It has to be. Patient safety is the absolute priority.
Okay, let's shift gears a bit to the psychobiological interventions. First, pharmacology.
Right. So we know mood disorders often involve imbalances in those neurotransmitters, serotonin, norepinephrine, sometimes dopamine in key brain areas. And while medications can be very effective, research consistently shows that combining pharmacological interventions with psychotherapy often yields the best results.
So, meds plus therapy is the gold standard.
Often, yes. When choosing an antidepressant drug, it's not one size fits all. It takes time, often 1 to 3 weeks, maybe longer, to see real improvement. The goal is complete remission of symptoms.
How do you choose which one?
Several factors: the patient's specific symptoms, potential side effects if they've responded well to something before, safety issues, and cost. And increasingly, we're using genotyping.
Genotyping, like genetic testing.
Exactly. Barcarolis mentions this in box 14.2. It looks at specific liver enzymes like the CYP450 system that metabolize drugs. People can be poor, intermediate, extensive, or even ultra-rapid metabolizers.
What does that mean for antidepressants?
It means someone might break down a drug way too fast so it never reaches effective levels, or they might break it down too slowly, leading to buildup and lots of side effects at a standard dose. Genotyping can help predict this, guiding clinicians to choose a drug or dose that's more likely to work well for that specific individual.
That's fascinating. So, personalization. What are the main types of antidepressants?
Okay, first-line therapy is often SSRIs, selective serotonin reuptake inhibitors. Think Prozac, Zoloft, Lexapro. They work primarily by increasing serotonin levels. They generally have fewer side effects than older meds, especially fewer anticholinergic effects like dry mouth or constipation.
But they still have side effects.
Oh, yes. Common ones can be things like agitation, anxiety, sleep issues, sexual dysfunction. That's a big one that affects adherence. And a rare but serious risk is serotonin syndrome.
Okay, what's that?
It's basically too much serotonin activity. Symptoms can range from mild, like restlessness, sweating, maybe diarrhea, to severe. High fever, muscle rigidity or spasms, myoclonus, confusion, agitation, even seizures, and potentially death.
Oh, what do you do?
Stop the offending drug immediately. Provide supportive care, cooling blankets, meds to control muscle rigidity or agitation, IV fluids. It's a medical emergency. Nurses need to recognize those symptoms.
Definitely. What other classes are there?
SNRIs, serotonin norepinephrine reuptake inhibitors, like Effexor or Cymbalta. They boost both serotonin and norepinephrine. Similar side effect profile to SSRIs, sometimes used if SSRIs aren't fully effective.
Okay. What about the older ones, TCAs?
Tricyclic antidepressants. These are older, effective, but have more side effects. They inhibit reuptake of both norepinephrine and serotonin, but also block other receptors, causing sedation and those annoying anticholinergic side effects, dry mouth, blurred vision, constipation, urinary retention.
Doesn't sound pleasant.
It's not ideal. And more seriously, TCAs can have cardiovascular toxic effects like causing heart rhythm problems, dysrhythmias, or even heart attack, especially in overdose. So they're used more cautiously now, particularly in older adults or people with heart conditions.
Okay. And the last main group, MAOIs.
Monoamine oxidase inhibitors, also older, also effective, but come with significant dietary restrictions. They work by inhibiting the enzyme MAO, which normally breaks down neurotransmitters like serotonin and norepinephrine, and an amino acid called tyramine.
Tyramine. Why is that important?
Because if someone on an MAOI eats foods high in tyramine, it can cause a hypertensive crisis, a sudden, severe spike in blood pressure.
What foods have tyramine?
Varkarolus lists them in Table 14.7, things like aged cheeses, cheddar, blue cheese, cured or fermented meats, pepperoni, salami, some beers and wines, soy sauce, sauerkraut, lots of things.
Wow, that's a lot to avoid.
It is. And they also interact with many other medications. Box 14.6 lists things like common cold remedies, other antidepressants like TCAs, narcotics. It requires very careful patient teaching.
What happens in a hypertensive crisis?
Severe headache, flushing, sweating, palpitations, maybe chest pain. It's another medical emergency requiring immediate treatment to lower the blood pressure.
Okay, so MAOIs need extreme caution. What about using these meds in specific groups, like pregnant women?
That's always a tough risk-benefit discussion. Antidepressants do cross the placenta. Some studies suggest potential risks like low birth weight or withdrawal symptoms in the newborn. But untreated depression during pregnancy also carries risks for both mother and baby. It requires careful conversation between the patient and her provider.
And kids and teens. There was that warning, right?
Yes, the black box warning from 2004. It noted an increased risk, though still relatively small, of suicidal thinking and attempts, not completed suicide, in young people starting antidepressants, especially in the first few weeks or after dose changes.
So do we avoid using them?
Not necessarily, but it means we have to monitor very, very closely. Interestingly, after the warning came out and prescriptions dropped, some data suggested suicide attempts actually increased. It's complex. The takeaway is vigilance and close follow-up.
In older adults?
Key issues are polypharmacy. They're often on multiple meds and physiological changes. They metabolize drugs differently, so the rule is start low and go slow with doses. They're also more vulnerable to side effects, like falls from orthostatic hypotension or the cardiac risks with TCAs.
Okay, lots to consider with meds. What about non-drug biological interventions?
Right. For severe treatment-resistant depression, electroconvulsive therapy, ECT, is actually one of the most effective acute treatments available.
ECT, that sounds intense. Isn't there a stigma?
There definitely is, often based on old movies or misconceptions. Modern ECT is very different and much safer. It's done under general anesthesia with a muscle relaxant, so the patient doesn't consciously experience the seizure or have convulsions.
How does it work?
A controlled electrical current induces a brief seizure, typically lasting less than a minute. It's usually done maybe 2 or 3 times a week for a total of 6 to 12 treatments. We don't know exactly why it works, but it seems to reset brain chemistry in a powerful way. Varkarolus has a figure showing the setup. It's very monitored and controlled.
Side effects?
The main ones are temporary confusion immediately after the treatment and some degree of retrograde amnesia, difficulty remembering events from right before the ECT course started. Usually this memory loss improves over time.
Okay. What else besides ECT?
There's transcranial magnetic stimulation, TMS. This is non-invasive. A device with an electromagnet is held against the scalp, and it delivers magnetic pulses to stimulate specific areas of the brain involved in mood, like the prefrontal cortex. Varkarolus shows a picture of this too.
Who gets TMS?
It's FDA approved for depression that hasn't responded to medication. It doesn't require anesthesia, and side effects are usually mild, maybe a headache or scalp tingling.
And there's vagus nerve stimulation, like
Yes,
meds.
right. This involves surgically implanting a small device like a pacemaker in the chest. A wire runs up to the vagus nerve in the neck. The device sends regular electrical impulses up the nerve to the brain. There's a figure showing the implant.
And this is for
Also for treatment-resistant depression, when other things haven't worked, side effects can include voice changes or hoarseness because the vagus nerve is near the vocal cords.
and deep brain stimulation, DBS. That sounds even more invasive.
It is. Electrodes are surgically implanted directly into specific brain areas thought to be involved in depression. Again, Varkarolis shows this. It's still largely investigational for depression due to the risks of brain surgery, like hemorrhage.
Wow. What about something simpler, like light therapy?
Yes, that's actually the first-line treatment for seasonal affective disorder, SAD, that pattern of depression linked to winter months.
How does it work?
Patients sit in front of a special bright light box, usually 10,000 lux, for about 30 minutes each morning. It seems to help regulate the body's internal clock and melatonin production.
And herbal options, like St. John's wort.
It gets mentioned a lot. Evidence is mixed. Some studies suggest it might help for mild to moderate depression, but it's not FDA regulated. Quality varies. And crucially, it can interact with many other medications, including conventional antidepressants, birth control pills, and blood thinners. Needs caution.
And finally, good old exercise.
Don't underestimate it. It has real biological benefits. It boosts serotonin, helps regulate that HPA-axis stress response. Plus, the psychological benefits, feeling accomplishment, social interaction if you exercise with others, it's a powerful tool.
Okay. And briefly, you mentioned advanced practice interventions.
Right. These are typically done by advanced practice psychiatric nurses, psychologists, or psychiatrists. Things like individual psychotherapy, especially CBT, cognitive behavioral therapy, and IPT, interpersonal therapy, which focuses on relationship issues that might be contributing to depression. And group therapy, which provides peer support and shared learning, is also very common and effective.
So after all these interventions, how do we know if they're working? Evaluation?
Exactly. Evaluation in nursing isn't just something you do at the end, it's ongoing, continuous. Are the interventions helping? Does the plan need adjusting?
What are you looking for?
You're constantly reassessing. Are suicidal thoughts still present? How's their sleep? Appetite? Are they engaging in self-care? How are their thought processes? Are they still dominated by negative thoughts? How's their self-esteem? You might ask directly, how do you feel about yourself now compared to when you first came in?
So tracking progress towards those initial goals.
Precisely. And this ties directly into quality improvement.
How so?
Well, healthcare systems are always looking at ways to improve care. There are national goals like the Healthy People Objectives, aimed at increasing the percentage of people with depression who get treatment, and promoting routine screening for depression in primary care settings.
And nurses are involved in that.
Absolutely. We're the ones implementing new evidence-based approaches, using those screening tools like the PHQ-9, collecting data, and participating in quality improvement initiatives on our units or in our clinics to make care better and safer.
That brings up a really important point related to quality and access. Cultural competence. Are there disparities in treatment?
Sadly, yes. Varkarolis highlights this. National studies show that individuals from racial and ethnic minority groups, for example, Latinos, Asian Americans, African Americans, often receive mental health treatment at lower rates than non-Latina white individuals, even when their needs are similar or greater.
Why is that? What are the barriers?
It's complex.
Yeah.
Factors can include things like difficulty taking time off work for appointments, the significant stigma still attached to mental illness in many communities, maybe historical mistrust of the healthcare system.
And maybe clinician factors too.
Yes, sometimes clinicians may lack experience or training in recognizing how depression might present differently across cultures. For instance, in some Latino cultures, distress might be expressed more through physical symptoms, somatization, rather than verbalizing feelings of sadness. Nurses have a huge role here in providing culturally sensitive assessment and care, advocating for patients, and maybe even developing community-based programs like home visits to bridge these gaps.
That's so important to address. Wow. Okay. We have covered a ton of ground in this deep dive.
We really have.
From all the different types of depressive disorders, the complex interplay of biology and stress, right through detailed nursing assessment, communication strategies, and this whole range of treatments from meds to ECT to light therapy.
Absolutely. And if you take a step back, the bigger picture here is that understanding these disorders isn't just about learning facts for a test.
Right.
It's really about trying to grasp the profound human experience of living with mental illness. It means appreciating all those interconnected factors, biological, psychological, social, few, and recognizing how we as nurses can intervene thoughtfully and compassionately across all those domains.
So for you listening, as you're working through this material for your nursing studies, what does it all mean? It means building a foundation that's not just for the NCLEX, though it will definitely help there.
It's about developing the empathy, the critical thinking, and the practical skills you'll rely on every single day to provide that holistic, patient-centered care that truly makes a difference. Host speaker and expert speaker. Thank you for joining us on this deep dive into depressive disorders. Remember, as you continue to build your knowledge in psychiatric mental health nursing, you are also cultivating the empathy and critical thinking essential for becoming truly transformative future mental health professionals. Keep asking those questions and keep making a difference.